Hi everyone, my name is Akshitha and I'll be discussing anesthesia for IONM. Anesthesia plays a pivotal role in the success of intraoperative neurophysiological monitoring, or IONM. During surgeries involving the brain or spinal cord, real-time monitoring of neural pathways can help prevent lasting neurological damage. However, the quality of this monitoring is directly influenced by the anesthetic regimen that's being used. For example, if anesthesia is too deep or pharmacologically inappropriate, it can suppress the very signals we rely on to ensure patient safety. Therefore, understanding the interaction between anesthesia and neurophysiological signals is very crucial for effective monitoring and improved outcomes. So there are four main ways that anesthesia can influence IONM performance: signal intensity, anesthetic type, muscle relaxants, and physiological effects such as blood flow and temperature. Some commonly used anesthetic agents in IONM include propofol and remifentanil, which are both administered as part of a total intravenous anesthesia protocol, also known as TIVA. We also have volatile such as sevoflurane or isoflurane, and lastly, there's muscle relaxants. And these agents have minimal suppressive effects on signals like SSCPs and MEPs, and that's referring to propofol and remifentanil. And in contrast, volatile inhalational agents such as reduce the amplitude of these signals and are generally avoided. Muscle relaxants are another important consideration. While they are useful during their prolonged use can eliminate EMG responses and irritation. Therefore, their use should be limited to the early phase of the surgery. Now coming to the critical impact of anesthesia, the first impact is on the signals themselves. Anesthesia, especially when given at high dosages, can reduce the amplitude of neurophysiological signals, meaning the signals can also increase latency. Responses take longer to appear. This is especially true for cortical signals like somatosensory and motor evoked potentials. For example, the deeper the anesthesia, the harder it becomes to detect early signs of neural compromise. Second, the type of anesthetic you use matters enormously. Inhalational agents like isoflurane or sevoflurane are known to suppress or even eliminate cortical signals even at low dosages. This makes them less ideal for cases requiring IONM. And on the other hand, intravenous agents such as propofol and etomidate are preferred because they maintain better control over the depth of anesthesia and they preserve the ability to monitor neural responses. Etomidate in particular is noted for enhancing the amplitude of SSCPs when used appropriately. And the third critical impact of anesthesia is related to muscle relaxants. Although they are important for intubation, they can significantly interfere with motor and EMG monitoring. If they remain in effect throughout the surgery, we lose visibility of spontaneous or evoked and cases relaxants are used mainly during induction and then avoided thereafter. This helps ensure that any signal loss is only due to surgical activity and not anesthesia. And finally, we have systemic physiological conditions like blood pressure and temperature, which can also influence IONM outcomes. For instance, if mean arterial pressure drops too low, cerebral perfusion is reduced, leading to poor signal quality. Similarly, hypothermia slows synaptic transmission and dampens signal strength. Maintaining normothermia and stable dynamics, therefore, is very essential for obtaining reliable, real-time neurophysiological data. It is essential to understand which anesthetic agents to avoid during IONM. For example, inhalational agents and nitrous oxide are known to interfere with cortical and subcortical signal acquisition. And long-acting neuromuscular blockers can also be detrimental, especially in procedures where muscle activity is being monitored. So the key is to keep the brain asleep while keeping the nervous system awake and responsive to stimulation. And avoiding these interfering agents allows for cleaner, more reliable monitoring data. So I mentioned TIVA before. Again, that's total intravenous anesthesia. and it is considered the gold standard for IONM cases. Now, this procedure is referring to when general anesthesia is being maintained by intravenous methods instead of inhalational agents such as sevoflurane. And this typically involves a combination of propofol and remifentanil. And this method offers several advantages, including rapid wake-up times, stable hemodynamics, and most importantly, preservation of evoked potential signals. So TIVA also avoids the pitfalls of inhaled agents, providing a stable neurophysiological environment where real-time monitoring can be conducted effectively. When titrated correctly, it supports both the surgical and monitoring goals without any compromise. So anesthetic plans must be tailored to the type of surgery and the neurophysiological modalities being used. For example, spine surgeries often rely heavily on SSEPs, MEPs, and EMG, making TIVA with no muscle relaxants the best option. And in brain tumor resections, particularly those involving allocrine cortex areas, a sleep-awake sleep technique is often used to facilitate language and motor mapping. For procedures like acoustic neuroma resection, which involve monitoring BAPs and facial nerve EMG, light TIVA without nitrous oxide is preferred. Therefore, each scenario presents unique challenges that the anesthesia team must accommodate. Another critical consideration in IONM is the potential for after discharges and seizures caused by cortical stimulation. When these occur, quick intervention is required. For example, the anesthesiologist must be prepared to administer ice-cold saline or adjust the depth of anesthesia to terminate the activity. So close coordination with the neuromonitoring team ensures that these issues are identified and resolved very quickly, minimizing patient risk. In conclusion, the anesthetic approach in IONM cases must strike a careful balance between adequate sedation and signal preservation. Total intravenous anesthesia, again, TIVA, involves using propofol and remifentanil, and this remains the cornerstone of successful neurophysiological monitoring. It's also important to note that avoiding volatile agents and prolonged muscle relaxation is very important, as is adapting the anesthetic plan to the specific surgical procedure. Most importantly, collaboration between the anesthesiologist and the neuromonitoring team is vital to ensure patient safety and surgical success. So overall, anesthesia in IONM is not just about keeping the patient asleep, it's an integral part of the monitoring process itself. Thank you.